So guys, the topic today under discussion is about the rectum, which is a very vital organ, and we're going to discuss about the different surgical conditions of the rectum as well. Rectum is connected, it is located in the lower abdomen, and above it is connected with the sigmoid colon, and downward it is leading to the anal canal, which is about 4 centimeter in length. And we know that the anal canal then opens to the exterior through the anal opening, where we have different types of the sphincter, which are called as the external anal sphincter and the internal anal sphincter. We'll be discussing about the anal conditions and the different presentation, but today we'll be talking about the surgical conditions of the rectum only. To know more precisely about the rectum, we should know what are the structures which are located anteriorly, which are located posteriorly, and which are located laterally to the rectum. So if we talk about the different kind of the anterior relationships of the rectum, we all know that rectum is basically just in front of the sacrum, and just in front of the rectum we have the bladder, we have the uterus, seminal vesicle, the novulus fascia, and prostate in case of males. And in particular, if we talk about the females, there's a pouch of Douglas, there's a rectovaginal septum. So in males, there are different structures which are located anterior to the rectum, and in females, there are different structures which are located in the anterior to the rectum. So we talk about the male's bladder and uterus. They are common in male and female both, but in case of the males, seminal vesicle, the novulus fascia, and prostate, they are located anteriorly. And in case of females, we have the pouch of Douglas, we have the rectovaginal septum as well. That's why most of the time, because of the anterior relationship between the rectum and the different kinds of pouch of Douglas and other anterior structures in the female, there can be a rectovaginal prolapse, which is a very common condition just after the delivery, because of the laxity of the musculature, vaginal musculatures. So you have to keep in mind these anterior relationships, because surgically and clinically they are very important. Other than that, in case of females, uterus and cervix, they are also located anteriorly to the rectum. If we talk about the lateral and the posterior relationship of the rectum, so laterally we have the pelvic autonomic plexus and levator ani muscle. We all know that if we talk about the anatomy of the anal canal, it is a very complex structure. We have the istiorectal fossa out there. We have other musculature like the levator ani and the puborectalis. And we have a perineal body, which is located in the center, and we have the internal and the external anal sphincter. So we particularly talk about the rectum. These structures are like the levator ani muscle. They are actually making the lateral boundary of the rectum. So you have to keep in mind the pelvic autonomic plexus, and you have to keep in mind the levator ani muscles as well. Besides that, if you talk about the sides of the pelvic wall, they're also located in the lateral relationship, and you have the obturator internus muscle as well, which is located laterally to the rectum. Beside that, we have the lateral ligaments, and we have the medial rectal artery. So what you have to keep in mind about the rectal lateral relationships of the rectum, that is the obturator internus muscle, plus the different sides of the pelvic wall, the levator ani muscle with the pelvic autonomic plexus, and also the lateral ligaments, which are sacrotuberous and sacrospinous ligament, which are actually forming the lateral boundary of the anal canal, and they're also the supporting ligaments for the different kind of the structures which are located in the anal canal. And in the lateral relationship, we have also got the middle rectal artery. So if we talk about the posterior relationship of the rectum, you have the superior rectal artery and the lymphatics. And we know that the superior rectal artery is a branch of inferior mesenteric artery. And regarding the middle rectal artery is a branch of internal iliac. So in posterior relationship, we have the Waldemar's facial condensation, and we have the sacrum and the hypogastric nerves and the coccyx. Out of all these, the plexus, which is lying in the posterior relationship of the rectum, is very important. That's called as a hypogastric nerves, which is also called as a superior and the inferior hypogastric plexus. So this was about the relationships of the rectum, but you should know basically that rectum is the tubular structure. And if we talk about the length of the rectum, it's about 8 to 10 centimeter in length, plus the composition involves the mucosal layer, then you have the submucosa, then you have the muscularis lamina propria and muscularis mucosa, and then you have the serosal layer. So we know that the mucosal layer, that is further subdivided into 3 different layers. The first layer is the epithelium, then you have the basement membrane, and then you have the lamina propria. At the end of the structures, we have the submucosal layer, then you have the muscularis layer, and then the deepest layer is called a serosal layer. If we particularly talk about the embryology, we all know that actually the gut develops like a continuous loop, which is further divided into midgut, hindgut, midgut, hindgut, proximal gut as well. So what happens that if we talk about rectum, so embryologically the embryological structure is the hindgut, which later develops into the sigmoid colon and the rectum as well. So it forms the upper part of the rectum, and the lower part is developed from the cloaca, which is enclosed by the extraperitoneal tissue. So what is actually the cloaca? That is the opening which is developed embryologically. So what we have to keep in mind that upper rectum developed from a different structure, and the lower rectum developed from a different structure. Upper rectum is developing from the embryologically hindgut, and the lower rectum develops from the cloaca, which is enclosed by the extraperitoneal tissue. So you have to keep in mind the concept of the primitive gut tube initially, because we know that the initially it is a primitive gut loop, which is divided later on into proximal, middle, and the hindgut, and they are all suspended by a mesentery. So the rectum is connected on its superior leg to the to basically the sigmoid colon, and downward it is connected to the anal canal. So whenever if we talk about the function of the large gut, we all know that the large gut is particularly meant for the excretion of the substances. A small gut is meant for the absorption and the reabsorption, and the large gut is meant for excretion of the substances. So whatever little bit of absorption also takes place, and the colon, like the sigmoid colon, and then the fecal material that comes into the rectum, and then from there the material is expelled into the anal canal, and then excreted to the anterior through the anal opening and the sphincters. Plus, we also should know that the rectal mucosa has a different kind of the musculature which is actually supporting the rectal wall. So we have to keep all these things in mind about the embryological origin. That is, the upper rectum is developing from the hindgut, and the lower rectum is developing from the cloacal opening, and a different kind of the muscles which are suspended in a mesentery are the levator-ani and external anal sphincter muscles as well, which are they are supported by the different kind of the lateral ligaments, and these ligaments are the sacrotuberous and the sacrospinous ligaments, which are very important in the perineal body as well, because most of these muscles of the anal canal, they actually converge and they insert on a perineal body, which is actually the central supporting structure which is present in the anal canal. So we have to keep all these things in mind. Regarding the blood supply of the rectum, you have to keep in mind that actually rectum is divided into upper part, middle part, and the lower part. So if we particularly look upon this diagram, we can see here that this is the actually the abdominal aorta, which is dividing into iliac vessels. So this is the common iliac, which is the right common iliac and the left common iliac vessels. So this is the inferior mesenteric artery, and the upper part of the rectum is supplied by the superior rectal artery, which is a branch of the inferior mesenteric artery. And we know that the inferior mesenteric artery is coming out from the aorta, just near to the division into the iliac vessels. So the upper part is supplied by the superior rectal artery, which is a branch of the inferior mesenteric artery. The middle part is supplied by these internal, this you can see here that this is the common iliac, the right common iliac, and the left common iliac. And then this common iliac is dividing into internal iliac and external iliac. So this is the external iliac and this is the internal iliac. So this internal iliac is actually supplying the middle part of the rectum. And the lower part of the rectum is supplied by the internal perineal artery. And this internal perineal artery is a branch of the internal iliac. So you have to keep in mind upper part is supplied by the superior rectal artery, which is a branch of inferior mesenteric artery. The middle part of the rectum is supplied by the internal iliac directly, which is coming from the common iliac, and the lower part of the rectum is supplied by the is supplied by the inferior rectal artery. And we know that the inferior rectal artery is a branch of internal perineal artery, and internal perineal artery is itself a branch of the internal iliac. So this was about the blood supply. You can see here in the diagram that this is the inferior mesenteric artery. This is the middle sacral artery. Actually, some of the branches of the middle sacral also comes, but not a significant proportion is from the middle sacral. This is also called as a median sacral as well. So this is the median sacral artery, which is directly coming from the abdominal aorta. And this is the internal iliac artery, and this is the superior rectal artery. So we know that this superior rectal artery, which is coming right here in the upper part of the rectum, is basically supplied by the inferior mesenteric artery. It's a branch of the inferior mesenteric artery. And this is the middle rectal artery, and middle rectal is directly coming from the internal iliac artery. And the lower part of the rectum is supplied by the internal perineal artery, and basically it's supplied by the inferior rectal artery, and inferior rectal is a branch of internal perineal, which is also coming from the internal iliac. So this is the inferior rectal. But this inferior rectal is coming from the internal perineal, and internal perineal is coming from the internal iliac. So upper part, superior rectal, middle part, middle rectal, inferior part, inferior rectal. Superior rectal, a branch of inferior mesenteric, middle rectal, a branch of internal iliac, and the lower part of the rectum, which is supplied by the inferior rectal artery, is a branch of internal perineal, which is a branch of internal iliac. So this was about the blood supply. Let's talk about the venous and the lymphatic drainage. So actually, there is a network of the veins which is called as the superior hemorrhoidal and rectal veins, and the inferior mesenteric and the splenic veins. So actually, the upper part of the rectum, the drainage, the venous drainage of the upper part of the rectum goes to the superior hemorrhoidal and the rectal veins, and the lower part that goes down to the inferior mesenteric vein and the splenic vein. And usually the drainage is upward and it is laterally limited, right? So regarding the venous and the lymphatic drainage, like the superior hemorrhoidal plus the rectal and inferior mesenteric vein and the splenic vein. These are the things you have to keep in mind, because the lymphatic drainage is very much important when we'll be discussing about the colorectal cancer and the spread of the metastatic cells. So let's just talk about that was brief discussion about the blood supply and the structure. Now let's discuss about the rectal features of the rectal disease. A patient is coming to you with typical symptoms. What are that symptoms that will actually give you a clue about the rectal disease? A patient can complain to you about the fresh bleed per rectum and the mucus discharge. Patient can complain to you about the altered bowel habit with the loose stool, or there can be proctalgia, which is basically the pain from the spasm of the levator-ani muscle, and there can be tenesmus and prolapse. So we will be discussing the symptoms one by one. First, if we talk about the fresh bleed per rectum and the mucus discharge, what comes into your mind when you are thinking about the differential diagnosis of the fresh bleeding? If a patient is saying that I have got a chronic constipation and plus there is a stool, there is a blood which is mixed with the stool, we'll probably think about we think about the hemorrhoids, right? But that's not a symptom which should be only limited to the the pathology of the anal canal. But sometimes a patient who has got a disease of the rectum, they also present with a fresh bleeding per rectum and the mucus discharge. Now, what do you mean by the altered bowel habit? The patient will say, sometimes I have constipation and sometimes I have loose stools. Whenever I eat something, sometimes it's not a chronic constipation constantly, or it's not a loose stool constantly. So they alternate with each other, and sometimes there is a constipation and there is diarrhea. And the patient complains of proctalgia. That means that whenever there is a rectal pathology, so the levator-ani muscles, which are located laterally to the rectum, and they're actually supporting these structures, they go into the spasm, and whenever they go into the spasm, they cause the pain. Patient can complain of a painful defecation or after the defecation. Now, the most grave symptoms that can be presented or that can be the major complaints of the patient, that are tenesmus and the prolapse. Now, what do you mean by tenesmus? Actually, tenesmus means the sense of incomplete evacuation. Like, the patient will typically say that whenever I pass the stool, even after passing the stool, I feel that my rectum is still loaded with a stool or with a feces. So usually he says that I feel like rectum has still got some of the feces or the stool. So this is called as tenesmus, which is the sense of, actually, this is just a sense, because he just feels that there's still more I have to defecate. But wherever the bulk of the stool, it's being excreted, but it's just a feeling that the patient feels that I need to pass more stool. There's something still left in the rectum. So this is called as the incomplete sense of evacuation, which is called as tenesmus. And the other thing is a prolapse. A prolapse can be mucosal prolapse, or a prolapse can be submucosal prolapse. That means that that is something coming out of the anus, or actually the rectal wall, rectal mucosa or rectal submucosa, that comes out of the anal canal. That's called as the prolapse. So you have to keep what symptoms in your mind. It can be PR bleeding. It would be a fresh bleeding per rectum with a mucus discharge. So whenever you perform the digital rectal examination, there is a tinge of blood or the mucus on your finger. Or there can be altered bowel habit with the loose stool, like sometimes there's constipation, sometimes there's a loose stool. The other thing is the proctalgia, that's the pain, and the other thing is tenesmus and the prolapse. So what signs you are going to look in a patient of a digital rectal examination? Whatever the complaints of the patient, you have to start from the abdominal examination. You have to examine the abdomen, you have to go for palpation, inspection, percussion, and then you have to go for auscultation. Why this is very important? Because sometimes, if there's a colorectal mass or probably the malignant mass, that can be palpated abdominally, right? So you have to start from the abdominal examination, and then you finish it, you notice the findings, and then you go for the digital rectal examination. So in case of the digital rectal examination, in case of females, you have to make a lateral decubitus position. You have to lubricate the surface. You have to lubricate your finger. The first 2-3 inches of your finger, they are enough for that. And then you insert your finger. And in case of a male patient, the tip of your finger or the pulp of your finger that touches the prostate. So this is the urinary bladder, and just in front of the bladder there's a prostate, because the urethra that passes down, and the prostate is surrounding the urethra. And also this is the whole of the urethra, and we know that the urethra has got the three different structures like penile, bulbar, and this is the testicles and the seminal vesicle and the vas deferens. So first, what kind of the information you are getting from the digital rectal examination, particularly it will give you about information about the prostate, like what kind of the information you can get through the rectal examination regarding prostate, the surface of the prostate, it's a smooth surface or a roughened surface, or even if the size of the prostate is enlarged or not. And then you have to look for any parectal bleed on your finger, and you have to look for the mucosal discharge, right? So because if there is polyp, you can also sometimes, if you go rectally or you perform the digital rectal examination, you can actually palpate or feel the rectal polyp as well, which is very much common in the children. So for these signs, you have to look for the rectal examination, and in case of the rectal examination, you have to look for the external appearance of the skin. You look for the anal fissure, you look for the hemorrhoid, the external pile, you look for the internal hemorrhoids, and you have to specify the position of the hemorrhoids, and you have to look for any kind of the internal mass coming from the rectum, because first 4 inches of the only 4 centimeter of the rectum, they can be palpated through the digital rectal examination. And also you can also palpate the surface of the prostate, like the smooth surface or the roughened surface. So in case of the digital rectal examination, what kind of the signs you have to look for? You have to do the proctoscopy as well. If you are only visualizing the rectum, like 10 to 12 centimeter of the rectum, then you have to go for the proctoscopy. Actually, what you do is you lubricate the surface. This is the proctoscope. You actually shift the patient to the theater, and you put the proctoscope parectally, and then you look for any kind of the bleeding, any kind of the mass, any kind of the impacted stool, or the bleeding hemorrhoids as well. So first is a digital rectal examination, but if the digital rectal examination is painful, in case of acute anal fissure, you do not proceed for the proctoscopy. But if the digital rectal examination is not painful and the sphincter tone is normal, then you will insert the proctoscope and you'll look for the 10 to 12 centimeter of the rectum. The other investigation, kind of the modality you use, is the sigmoidoscopy. in which you go parectally, but actually you visualize the sigmoid colon as well. It's a kind, proctoscope is small, but the sigmoidoscope is a long scope. So you insert this through the anal canal, and then you goes down here, and it also, you can also, there's a camera with that and a light as well. So what you visualize, the internal surface of this sigmoid colon, you visualize the anal canal, you go for the rectum, and then also the sigmoid colon as well. So DRE, which is the digital rectal examination, then you go for the proctoscopy, and then you go for the sigmoidoscopy if the patient is actually complaining of altered bowel habits or perectal bleeding or mucosal discharge. You have to perform all these one by one. And there's another flexible sigmoidoscope. It's actually the proximal surface is actually very flexible, and whenever you put this scope inside, it actually it's very flexible. So it changes the position according to the loops. Like if it's in the rectum, and then it goes, it tells to some other position to visualize the sigmoid colon. So flexible sigmoidoscopy is another very helping instrument which can be used. So what kind of the injuries you can encounter in case of the rectum? But sometimes there can be a person is playing, and or if the person is in a sitting position, he fell in a sitting posture. So sometimes it can injure the rectal mucosa. And also there can be penetrating injuries to the buttock, or there can be the history of the sexual assault or sexual activity, or there can be fetal head during the childbirth. So these all things, actually the history of the patient is very much important, because all these things can lead to the rectal injuries, which are involving falling in a sitting posture, penetrating injuries to the buttock. There can be sexual assault, or this any kind of the sexual activity that can also damage the rectal mucosa, or there can be fetal head during childbirth. So what happens is, actually all these injuries, the patient can come to you with a prolapse, or the patient can complain of a perirectal bleeding. So this was about the injuries, how you are going to make a diagnosis. You start from the abdominal examination. You start from the history, actually. You have to take a detailed history, then you have to perform the examination. In particular, the examination, you have to start from the abdominal examination. Then you do the anal inspection, you do the digital rectal examination, you perform the proctoscopy or sigmoidoscopy. And in case if you are unable to make the diagnosis with such kind of investigations or interventions, then you have to go for the laparoscopy, and you actually insert the laparoscope, and you go, because sometimes if the lesion is involving the upper part of the rectum, and it's involving the sigmoid colon as well, and sometimes the lesion is not easily picked up. So what do you go for? You go for laparotomy in case of the abdominal tenderness, or you go for the laparoscopy. And obviously for the pelvic injuries, like the urethral injuries, you order for the CT scan, because if there is a urethral injury, there's a history of fall, there's a urethral injury, there's a bladder injury, or there's a rectal injury, then you perform the fast scan, and you go for the CT scan as well, so that you can actually know about the extent and the location of the injuries. What kind of the treatment you're going to give to your patient? First of all, you examine it with a sigmoidoscope. And other thing is that if there is an extensive injury to the rectum, you go for the hot pin procedure, and you actually make you resect that particular segment, and which is being injured, and there is the injury is kind of a penetrating or a crush injury. Then what you do is you do the hot pin procedure, you resect that particular segment, and then you do the colostomy. And for a considerable time the colostomy bag is attached to the patient, and after when the anastomosis is ripened, you do the reversal of the colostomy, or what else you can do is closure with the sutures, and dysfunctional rectum is bring to the exterior in the form of a stoma, and then that is exteriorized and then later resected, and then the primary anastomosis is established, and the reversal of the colostomy takes place later on. And plus you have to go for the good antibiotic cover, the aerobic cover, and the anaerobic cover as well. There can be different kinds of the foreign bodies in the rectum. You can see here, this is a picture of the barium enema. You give the enema parectally, and then you visualize that the rectum in the sigmoid colon. So you can see here that in the dye, the dye is actually giving you, or the enema is actually telling you about this kind of the foreign body. So there can be kind of foreign bodies in the rectum. So what kind of the treatment you perform, it depends upon the foreign body location. If it's in the lower rectum, then rectotomy is sufficient. If in case of the it's involving the upper rectum and the colon, like in case of this previous slide, you can see here it's involving the sigmoid colon. So in case of this, it's high up in the rectum or it's in the sigmoid colon, then you go for the laparotomy. But in case of the lower rectum, you have to go for the rectotomy, or sometimes you have to go for the temporary colostomy. So this was the treatment about the foreign bodies, and the patient can complain you about the presenting complaint of the patient can be a prolapse. Now, the rectal prolapse can be a mucosal prolapse, like only the mucosa of the rectum is being prolapsed. The rest of the different layers of the rectum, they're in place. But sometimes there can be a submucosal prolapse, and the prolapse can be secondary to injury, or a prolapse can be after the childbirth, which is the rectovaginal prolapse most of the time. So there can be a partial thickness prolapse involving the mucosa, submucosa, or there can be a full thickness prolapse. Like in case of, you can see here, this is like in infants and children and in adults. We're going to discuss the type of the mucosal prolapse one by one in all these entities, like in infants, in children, and adults. In case of the infants, it's only the downward course of the rectum. But in case of children, it's after the diarrhea or from the weight loss, and it's actually related to the rectal polyp in most of the time, or it's related to the cystic fibrosis, which is a very common disease in case of the children. And in adults, this rectal prolapse is associated with the third-degree hemorrhoid. So in infants, it's only the simple downward protrusion or down course of the rectum. In children, it is secondarily to diarrhea or secondarily to weight loss, and is also linked with the cystic fibrosis and different kind of the rectal polyps, because I told you previously that rectal polyposis or solitary rectal polyp, this is very much common in the children. And in case of the adults, this mucosal prolapse is associated with the third-degree hemorrhoids. It can be a mucohemorrhoidal prolapse. You can see here, actually, there's a fourth-degree hemorrhoid, right? That means a fourth-degree hemorrhoid is a prolapse hemorrhoid, that the internal hemorrhoid that has just exteriorized, and it's a prolapse. And so it's not going anywhere inside on its own, but you have to perform the surgery. So it can be a mucohemorrhoidal prolapse in which the hemorrhoid, along with the rectal mucosa, that prolapse through the anal opening. So in adults, it can be a mucosal prolapse of solitary involving only the rectum, or it can be a mucohemorrhoidal prolapse. So in case of the treatment, in case of the this prolapse of the rectum, what are the treatment options we have with us available? Like in case of infants and the young children, we go for the digital repositioning, or we go for the submucosal injection or banning. Like in infants and young children, what do you mean by the digital repositioning? That means that you're just only trying to push, because it's there's no actually pathology in case of the infants. It's only the downward protrusion of the rectum. So you push the rectum back to its original position through your fingers, which is called as a digital repositioning. But sometimes you have to go for the submucosal injection, and you have to go for the banding as well. So in adults, you go for the local treatment like the submucosal phenol injection with the almond oil. Actually, it's actually acting as a sclerosing agent. It burns out the base of the prolapse, and the whole of the structure which is being prolapsed is burned out with the sclerosing agents, and the rest of the rectal mucosa is pushed back, and or you go for the prolapse mucosal excision. So keep in mind, in infants and young adults, you go for the digital repositioning, and in case of the young children, you go for the submucosal injection or banding, and in infants, you go for the submucosal phenol injection, which is a sclerotherapy, or you go for the excision of the pure prolapsed mucosa, or it can be a full thickness prolapse. You can see here all the layers of the rectum, they've got prolapsed. So this is called as a full thickness prolapse, in which the whole, not only the mucosa, the submucosa of the rectum is being prolapsed, but actually the layers of the rectum is being prolapsed. So this is called as a full thickness prolapse. There are two approaches for the treatment of the rectal prolapse. So one is a perineal approach, and the other is the abdominal approach. So in case of the perineal approach, there are three procedures you can perform. One is a thirst operation, in which the only what you do is you resect this mucosal layer, and then you push inside the rest of the mucosa. You can see here, this is just kind of the only mucosal layer is being separated from the rest of the rectum. But what happens is, like, this is not a very successful operation. Why? Reason being, it has more percentage of perineal sepsis, which is linked to this procedure. So nowadays, this procedure is not very much favored, and it's not performing nowadays. The other procedure is the Delorme's operation, and in case of the Delorme's operation, you can see here, actually, you do not actually, it's in case of the mucosal prolapse. You actually strip the mucosal layer. You can see here that with the help of the small knife, he's actually stripping off the mucosa, and then the rest of the mucosa, you do the intervention suturing. You can see here, these are the interrupted sutures. You actually separate the mucosal layer, which is called as the stripping of the mucosal layer, and then you do the interrupted suturing. This is called as a Delorme's operation. This is a very successful operation, and this is performed. In case of the full thickness prolapse, you perform the Altimere's procedure. And in case of the Altimere's procedure, it's a full thickness prolapse. So you actually the whole of the layers of the rectum which are being prolapsed, they are resected. So it's only the resection, and the rest of the remaining portion of the mucosa, you go for the secondary suturing. So this is the Altimere's procedure. There is another technique which is called as the laparoscopic ventral mesh rectopexy. For the complex prolapse or the colorectal prolapse, you go for the abdominal approach. You do not go for from the perineal approach. So in case of the abdominal approach, you go for the laparoscopy, and you put the mesh, you can see here, you put the mesh between the colon and the rectum. This rectum, this is the colon. You strip the mucosal surface, and then you put the mesh between the colon and the rectum. So this is called as the laparoscopic ventral mesh rectopexy. Okay, so let's just talk about another condition of the rectum, which is the solitary rectal ulceration syndrome, which is called as a SRUS. So in SRUS, what happens is the patient presents with a solitary rectal ulceration. It can be secondarily to other diseases like the inflammatory bowel disease involving the Crohn disease or the ulcerative colitis, but most of the time it is the rectal intussusception which leads to the ulceration formation in the rectal mucosa. So actually, this is also called as a rectal evacuation disorder, or it's called a solitary rectal ulcerated syndrome. And it actually is associated with the rectal intussusception, and this solitary rectal ulcer syndrome takes from the kind of the ulcer, because I told you that in case of the patient who are suffering from the altered bowel habits for a very long time, constipation alternating with the diarrhea or inflammatory bowel disease like the Crohn disease and the ulcerative colitis, so all these things actually lead to the solitary rectal ulceration syndrome. And for that, you go for a biofeedback therapy, and you also go for a START procedure. In case of the START procedure, you excise this. What you do is this is a kind of the mucosa which is forming the ulceration in the rectum, right? So what you do is that you excise this in a shape of a star. So this is called as a START procedure. The other entity we are going to discuss is about the proctitis. And proctitis, there are different kinds of the proctitis, like the ulcerative proctocolitis, or there can be a radiation proctitis, or there can be secondarily to injury, or they can be because of a Crohn disease proctitis, or they can be a gonococcal proctitis. So proctitis is actually the inflammation of the rectum, and there are many causative agents. One is the ulcerative proctocolitis. That means, the proctocolitis, which is associated with the ulcerative diseases like the ulcerative colitis, right? So this is the inflammatory bowel disease. So it doesn't only involve the colonic mucosa, but it also involves the the rectum as well. So whenever the rectum is involved along with the colon, in case of the ulcerated colitis, that's called as ulcerative proctocolitis. And proctitis can be because of the Crohn disease, because we know that in the Crohn disease there are variable skip lesions, there are ulcerations, multiple ulcerations, and all these things also damages the rectal mucosa as well, and they lead to the proctitis, which is due to the Crohn disease. The other is the radiation proctitis, right? Now sometimes, in case of the colorectal cancer, or in case of the vaginal cancers or cervical cancers, the patient is given a lot of radiations to that particular area, and that is called as a radiation proctitis, because that radiation exposure lead to the erosion of the protective layer which is present in the rectum, and then that lead to the proctitis. So radiation associated proctitis is another important entity. Proctitis can be because of the specific infections, and these specific infections include the Clostridium difficile. It can be a bacillary dysentery, or there can be a mimic dysentery. So we have to treat proctitis according to the cause. If there's a radiation proctitis, there's not a lot of you have to do, just give the prophylactic antibiotic. You have to stop the radiation therapy for some time, and if there is a specific infection associated, you have to treat the Clostridium, you have to treat the bacillary dysentery, or you have to treat the amoebic dysentery. And there can be other causes of the proctitis, like the tuberculous proctitis, which can be submucosal rectal abscess and ulcers. There can be gonococcal proctitis, in which there is a hyperemic mucous membrane, or there can be a lymphogranuloma venereum, which is the chlamydial infection which is spreading from the cervix, which is very much common. You have to identify what kind of the proctitis is this, and then you have to treat that accordingly. Like in case of the tuberculous proctitis, you have to put the patient on anti-tuberculous therapy, like the like different kinds of the rifampicin, isoniazid, or pyrazinamide. And in case of the gonococcal proctitis, there would be hyperemic mucous membrane. You have to go for the specific therapy. And in case of the lymphogranuloma venereum, you have to treat the chlamydia infection. So if we talk about the lymphogranuloma venereum, this is most common with AIDS, acquired immunodeficiency syndrome, and patient actually the kind of the lesion or the proctitis is a florid type of the proctitis. You can see here, actually it is it's associated with the AIDS, but the specific feature you'll get it here is a florid type of the proctitis. Or there can be a strawberry lesion of the rectal sigmoid, and if there is a strawberry lesion, you can see here different kinds of the strawberry lesions are present. So in the rectal sigmoid, so they can be because of Spirochetia vincenti, or they can be a Bacillus fusiformis, or there can be a rectal basariasis, and you have to, it is caused by the schistosoma mansoni, or most of the time it is commonly associated with the papillomas, or there can be a proctitis due to herbal anemia. So you one by one you have to treat all these cases according to their on type. And in case of the proctitis due to herbal anemias, there is actually the mucous membrane is extruded because of the gelatinous cast. And there's another important entity, which is the rectal polyp, and this is very much common in the young children. And the polyps, they can be isolated, they can be edematous, adenomas, they can be tubular, they can be villous, or they can be hyperplastic polyps. Usually the polyp of the size less than 1 centimeter is benign, but this size is greater than 1 centimeter, the chances of the malignancy is more. Probably because in case of the hyperplastic polyp, malignancy is the chance of the malignancy is about 1%, and there's a more risk of malignancy in case of the hyperplastic or the tubulovillous adenomas. But in case of the hematomatous polyps, these are not associated with the malignancy, and there is another entity which is called the serrated polyps. And in case of the serrated polyps, they also have increased risk of malignancy, and they're called serrated because of their serrated appearance. You can see here, this is the rectal mucosa, and the polyp is coming out there. What are the polyps relevant to the rectum? Serrated adenomas. They're called as the serrated adenomas because their borders or their surfaces are serrated, as you can see in the picture. They can be tubular adenomas because they have the appearance of the tube. There can be a juvenile polyps, which are common in the young children, and there can be hyperplastic polyps as well. So if we talk about the serrated adenomas, they are more prone for malignancy, and the tubular and the tubulovillous, they're also more prone for the malignancy, and they are also associated with the different kind of the polyposis syndrome, which is called a familial adenomatous polyposis. And in case of the hyperplastic polyps, if their size is greater than 1 centimeter, then they have the risk to develop the malignancy. You can see here there's a villous adenoma. This is called a villous adenoma because they have the villi on their surfaces. This is familial adenomatous polyposis, and it is associated with the APC genes, adenomatous polyposis coli genes, and there can be inflammatory pseudopolyps. So this is condition, inflammatory polyps or the hematomatous polyp. They're not there's less likely risk for the malignancy, but in case of the villous adenomas and in case of the familial adenomatous polyposis, there is increased risk of malignancy. So for the rectal polyp, if the size is less than 1 centimeter, or if the size is ranging between 1 centimeter to 4 centimeter, you only go for the endoscopic mucosal resection. You can see here it's a mucosa, and the lesion is smaller in size and is confined to the rectal mucosa. And this is a muscularis mucosa. But if the lesion is just, this is the mucosal layer, this muscularis mucosa, and then submucosa, and this is muscularis propria serosa. So actually you remove this lesion, and through the endoscopic mucosa, you insert the endoscope here, you go from submucosa, and you remove the lesion with the mucosa. So this is called as endoscopic mucosal resection. You can see here in this diagram as well, the lesion is removed, or you can go for the laparoscopy, because nowadays laparoscopy is also being performed. There's another entity which is called endometrioma, and that the B line, this is not actually a benign condition, but actually this is a misnomer. Endometriomas are actually the ectopic endometrial tissue which is growing in any other place. So in case of the endometrioma, they can be anywhere. Normal endometrial tissue can if abnormally grows anywhere like in the fallopian tubes or in the ovaries or in the rectum. So what you do is that's called as endometrioma, but it's not a tumor, it's just a misnomer for that. It's not a carcinoma. But whenever you perform or try to look for them, like if you do the laparoscopy, so their surface is kind like it gives you a clue about the carcinoma, but it's actually not a carcinoma. So in case of endometrioma, you do the total abdominal hysterectomy or bilateral self-oophorectomy, or then you go for the bowel resection. It depends upon where the endometrioma is. If it's in the abdominal cavity, or it's involving the anywhere else, so you do the total abdominal hysterectomy with bilateral self-oophorectomy, like you have to remove the ovaries as well and the fallopian tubes as well. And if the endometrioma is involving the colorectal part, then you go for the bowel resection as well. So this was about the different conditions involving the rectum. In the different another presentation or lecture, we will be talking about the benign and the malignant lesions of the rectum. So thank you for watching sqadia.com. Keep watching.